All right, buprenorphine and pain. My name is Caitlin Kawada. I'm a geriatrician and palliative care physician here at Los Angeles General Medical Center. Okay, no conflicts of interest or financial disclosures. The objectives of today's talk are to understand the evolution of buprenorphine use in history, define the pharmacodynamic properties of buprenorphine, identify the patient populations in which to consider the use of buprenorphine, identify the available buprenorphine formulations and understand their unique qualities, and learn some of the nuances of prescribing buprenorphine using case examples. My hope is this talk will be very practical and really get your feet wet on to figure out how to use this medication, as it has been around for some time, but I can understand it may be the first time you're considering using or prescribing this medication for your patients. So what will not be covered? I will not be covering IV buprenorphine or the inpatient protocols. I will not be covering extended release buprenorphine, how to rotate from methadone to buprenorphine, or any perioperative management. This is really meant to be an introductory lecture on what buprenorphine is and how to consider using it and what your first steps would be if you were to prescribe it. So before we get started too much into the material, I want you to give a chance to quiz your knowledge. So on the next slide, there will be some questions that are true or false, and I want you to take a moment to pause the presentation and see how you answer. Hopefully throughout the presentation, you will have more information and know if you're right or wrong, but otherwise there'll be answers at the very end of the slide deck. So here's the quiz. Again, go ahead and pause your videos. You can quickly do these true or false questions. So getting into the background of buprenorphine, it was originally in 1966 discovered in the labs. And in 1978, it was launched in the UK as an IV opioid analgesic. So it's really important to acknowledge the first time it was used, it was for analgesia. Then in 1981, the FDA approved the injectable version as a Schedule II opioid. And it wasn't until 2002 where the FDA approved its sublingual version, commonly known as Suboxone for buprenorphine combined with naloxone, as a Schedule III opioid. And this is a lot of times where people heard of buprenorphine was from the purposes of treating opioid use disorder in 2002. Then we have in 2010, the FDA approving the transdermal version of buprenorphine, commonly known as Butrans. And this was for the indication of severe pain and chronic pain. And lastly, in 2015, the FDA approved buprenorphine buccal film. The buccal film Belbuca was for the management of severe pain as well. And it's really important to just see that it was discovered back in 1978, 2002 when it became popular for use in opioid use disorder, and then later 2010 and 2015 is when the FDA approval for chronic pain management with buprenorphine came into effect. So it's really important to just take home the message that you can use buprenorphine for chronic pain and or for opioid use disorder. You do not need to have opioid use disorder to consider buprenorphine for treatment of chronic pain. So just a quick review of scheduling of opioids, because I think it does play into how we think about the safety of medications, right? So scheduling are done as a way to help stratify a likelihood of medication causing dependence when abused or relative abuse potential. So you have Schedule 1 through 5. And so most commonly, we think of Schedule 2 medications as our prescribed opioids, so hydromorphone, methadone, oxycodone, fentanyl. Then we have Schedule 3, and this is actually where we have our buprenorphine Suboxone listed, along with ketamine and Tylenol with codeine. Schedule 4 would be like Xanax or Tramadol. And Schedule 5 are like cough preparations that have a lot lower dose with the codeines. But as you can see, technically Suboxone as buprenorphine is a Schedule 3 medication. So potential lower risk for abuse compared to the Schedule 2s that we commonly are using all the time. So the other big point I wanted to bring up was there's no longer the need for the DEA-X waiver. So what do I mean by that? So in 2000, there was the data waiver. And basically, this was a waiver that said that for those with opioid use disorder, you could be prescribing medications only if you had this specific waiver. However, in 2023, they had the Consolidated Appropriations Act. And this was groundbreaking because it really took away that special requirement for having a waiver prescribe buprenorphine, which means at this point in time, if you are a physician with a standard DEA that can prescribe level Schedule 3 medications, you can prescribe buprenorphine. Doesn't matter why you're prescribing, for pain or opioid use disorder. You can prescribe buprenorphine without anything special. You just need to have a standard DEA. You do not need the X waiver of any kind. I am specific in saying physicians because depending on the state you are in, non-physician practitioners may have other rules that limit their buprenorphine prescribing abilities. So just to be aware, it may depend on your state if you're a non-physician practitioner. But overall, this was a big win because before then, you had to have special training. Not everyone could prescribe buprenorphine, and it made it seem like it was a very restricted medication, more restricted than morphine or more restricted than oxycodone, when this really should not and is not the case. So before we dive into the logistics of prescribing, I really want to take a step back because a lot of what makes buprenorphine so unique and special compared to traditional opioids is how it acts at the receptors, also known as your pharmacodynamics. However, before we talk about how it interacts at the receptors, it's important to clarify some definitions. So, quickly probably taking you back to training, thinking about your pharmacodynamic definitions. Go ahead, feel free to pause this to quiz yourself, but I'll give you the answers. So in terms of buprenorphine's pharmacodynamic properties, so in terms of potency, it's a relationship between a drug dose or concentrations and specific response intensity. Buprenorphine has a high potency and slow dissociation rate, allowing for effective and long-lasting analgesia at very low doses. In terms of affinity, it has a very high affinity at the mu-opioid receptor. And we'll get into this a little bit later, but this is a big reason why there's a potential risk for withdrawal when you give a high dose of buprenorphine to someone who is already on a full traditional mu-opioid agonist like morphine. Because of the high affinity, buprenorphine is going to want to jump on those receptors and potentially kick off the other opioids that are taking up those receptors and temporarily cause a withdrawal. Then we get to partial agonism. So a partial agonist, such as buprenorphine, has lower mu-opioid receptor signaling than a full agonist. And this is the reason why it has less activity at the receptor in terms of some of its downstream effects. So the less intrinsic activity is the reason why an buprenorphine has less negative effects compared to traditional opioids. So we'll go into a little bit more detail of clinically what this means, but basically it activates the opioid receptors, but how it activates it or to the degree it activates it is different, and therefore you have less risks of side effects. However, you still do have analgesia provided. So to just take a step back, when I was talking earlier about the buprenorphine having high affinity, here's just kind of a visual representation of how you think about it, in the sense that in your orange pentagons, you can see it takes up a lot of the receptors over here with the traditional opioids. And if you were to throw in a large dose of buprenorphine, you would quickly kick out all these traditional opioids, and that would lead to this precipitated withdrawal. So a little bit later in this talk, what we'll do is we'll walk through an alternative way to give buprenorphine, which is maybe considered low dose protocols or gradual providing of buprenorphine to the receptors. So over time, they slowly take over the receptors, and so you don't get a precipitated withdrawal. And then in terms of the receptors, so we already talked about the mu-opioid receptor. There's also some research showing that it activates the ORL1 receptor. Again, both of those are responsible for analgesic purposes. However, it doesn't necessarily trigger the other pathways of these receptors because it's a partial agonist with certain intrinsic activity. And for that reason, buprenorphine has a lower risk of respiratory depression compared to traditional opioids. So that's really important, is you still have analgesia with buprenorphine, but there's a lower risk for respiratory depression. It's not zero, right? It's still an opioid. It still has that risk of respiratory depression, but it's a little bit less compared to potential true traditional agonists like morphine or oxycodone. But it does have the ability to provide analgesia. So partial agonism does not mean partial analgesia. So again, the benefits of buprenorphine are based on its receptor activity. There's lower risk for respiratory depression. There's lower effect of euphoria or highs. There's lower risk for sedation, and there's lower risk for hyperalgesia. All of how it interacts with the receptors that makes it different than traditional opioids. So the next question that comes up is, what patient populations can find buprenorphine helpful? And I want you to think about it as just any other tool in your toolbox, right? You're not going to consider buprenorphine for just anyone, just like you wouldn't prescribe morphine or oxycodone for just anyone, right? You have to meet those certain parameters that you would be considering an opioid in the first place. Like, it's still just another tool to think about. But if you were finding a patient who you did think an opioid would make sense for whatever reason, I want you to think about buprenorphine, especially for the following people: those who already have opioid use disorder, or those who have chronic pain and they have a history of opioid use disorder or history of overdose, or there's concerns for possible opioid misuse. It's also worth considering in chronic pain patients who have renal dysfunction, including those with end-stage renal disease who are on dialysis. It is not removed during dialysis, so you can definitely use this in the HD population. I would consider using buprenorphine for chronic pain in treating older adults, those with long-term opioid use, and anyone who's not tolerating the adverse effects of opioids. And the other group to really think about using buprenorphine for chronic pain is those who have dysphagia and cannot tolerate the traditional PO pills or capsules that other opioids may come in. So that's just another thing to think about, is the delivery of, maybe that's a reason they can't use buprenorphine. And I would also say that because there is a lower risk for opioid use, I would also say because there is a lower risk of respiratory depression, you could consider using buprenorphine in those with chronic pain who already have a high risk for problems with from a respiratory standpoint. So those with lung diseases or on other sedating medications, like the gabapentinoids, right? So maybe those higher risk patients who you're worried about respiratory depression, consider using buprenorphine over another opioid agonist because it possibly a little bit less risk. Other special considerations in terms of your patient populations. So for liver dysfunction, you can dose reduce for those with moderate to severe liver dysfunction, but if someone has very stable cirrhosis and it's compensated, you don't have to worry about adjusting your buprenorphine dosing. And the other thing to be just mindful of is not buprenorphine, but naloxone needs to be adjusted if there's severe liver dysfunction, in the sense that you're higher risk for naloxone building up in those with severe liver dysfunction. And so you may opt out of using the combination of buprenorphine plus naloxone for that population who has severe liver disease. You may use buprenorphine alone. QTC prolongation. So there are no clinically meaningful studies that show change affected by QTC prolongation for buprenorphine. They do show that QTC prolongs, but it doesn't clinically cause significance. It's important to know, a lot of times for patients who are on methadone with QTC prolonging as a side effect, a lot of prescribers will rotate from methadone to buprenorphine because it's actually safer. And you end up having a resolution of the prolonged QTC. But you do not need to do any special cardiac or serial EKG monitoring if you start patients on buprenorphine. And then, the other thing just to be aware of is you wouldn't necessarily want to use it in someone who already has problems with prolonged QTC or long QTC syndrome, right? Like if you're already starting with a population, it could be worrisome. Maybe that could be a reason to be a little bit wary, but you're not doing routine monitoring. Dental concerns. So in January of 2022, the FDA had provided a warning about the dental problems associated with buprenorphine medicines dissolved in the mouth. However, this is very misleading, and the American Society of Addiction Medicine, along with 10 other professional organizations, wrote a letter really asking for retraction of this warning. And the reason why was the evidence for this warning was quite weak. It was a lot of case reports of people having dental problems who was using buprenorphine, 305. However, when you look at the number of people in general using buprenorphine, it's a much larger population using it without any side effects. And these were not randomized trials that gave this data to suggest there was problems. These were case studies. It was association, not causation. And the other thing to be really mindful of is a lot of the people who are using buprenorphine were for opioid use disorder, and a lot of people who had opioid use disorder were not necessarily seeking dental care. And so you have kind of a certain patient population that maybe has decreased access to resources, maybe more risk for having dental problems separate from the buprenorphine use. So I just really want to counsel that yes, there is this warning, and also for the majority of patients, the benefits likely outweigh the risks. And even the thought process that led to this warning, isn't really backed up by randomized controlled trials or a lot of evidence. So if your patient asks about it, you can have a conversation, but it's never been a reason for me to not prescribe it. So now we'll talk about the different formulations of buprenorphine. I like to break it down into two categories: your low dose here, your transdermal, and your buccal films, and then I'll go through the high dose next. So in terms of your low dose formulations, the FDA indications are for pain. They're meant to be used for pain. But off-label, you can use them as low dose initiation protocols, perhaps for someone who has opioid use disorder and you're trying to gradually get them on to buprenorphine. You could use in that capacity. And really, you want to consider your low dose formulations for patients who are opioid naive or their oral morphine equivalent is less than 80. And the reason this parameter of 80 is helpful is it gives you an idea for if the low dose formulations are going to provide enough analgesia, right? It may be one thing if you're using it as a stepping stone to the higher dose formulations, but if someone's using more than 80 oral morphine equivalents, the low dose formulations of buprenorphine may not be very successful in treating their pain completely. So the first one I'll talk about is the transdermal Butrans. It's dosed every 7 days, which is very convenient for patients and caregivers. The lowest dose is 5 micrograms per hour, and the highest dose in the United States is 20 micrograms per hour. This was due to some earlier studies that showed that higher doses of the patch potentially could cause QTC prolonging. Outside the US, they do higher formulations. It takes 72 hours to reach peak effect, so it does not work right away in full strength. And this is important when you're counseling your patients because they're going to expect it to work right away, right? They want pain relief, and you have to explain to them that it takes time to build up. So to not just get rid of it or give up right away just because they don't feel the full effect. And because of that, it takes 72 hours to reach steady state. So the soonest you would want to change your dose is after 72 hours. You wouldn't want to do it any sooner because it's still ramping up. And just in terms of the starting dose, and this comes right from the Butrans prescribing guide, if someone is opioid naive or they're using less than 30 oral morphine equivalents, you would want to do 5 micrograms per hour as your starting patch dose. And you can never go wrong, right? In general, for going low and slow is to start with the 5 micrograms per hour. But it just may be that you have to titrate up. If someone is using 30 to 80 milligrams or oral morphine equivalent, so someone who is not opioid naive, you could argue to start directly at the 10 microgram per hour patch. So maybe you already know they're going to need a little bit more right off the bat. You could start them off at 10 based on 30 to 80 oral morphine equivalents. So next we'll talk about the other low dose formulation, which is your buccal film, also known as Belbuca. It's dosed usually every 12 hours. It's much more frequent. Your dosage formulations go from 75 to 900 micrograms. So it's a pretty big range. It takes about 3 hours to peak effect, so much faster than the Butrans patch, but compared to like an oral oxycodone or morphine, it does, take a little bit longer. It's a long-acting version, right? Q12 hours. And it takes about 4 days to reach steady state, so that's the minimum titration interval. In terms of actual choosing your starting dose, so if someone is opioid naive, or if they're using less than 30 milligrams of oral morphine equivalents, then you would start at 75, either once daily or every 12 hours. If they're kind of in that 30 to 89 range of oral morphine equivalents, you can use 150 as your starting dose every 12 hours. If they're at 90 to 160, then you could start with 300 micrograms every 12 hours. And if someone is using more than 160 oral morphine equivalents, consider an alternate analgesic. And again, it just comes down to, like, at the much higher oral morphine equivalents, how much the Belbuca is going to be able to handle in terms of analgesia has its limits. But again, it's really great for those people who are of lower or oral morphine equivalents or opioid naive. They also do say that ideally you would want to taper down someone to down to the 30 oral morphine equivalents before you even initiate Belbuca. But acknowledging, right, it may be really hard to test a taper our patients. And so it may be kind of a barrier for how low you can go before you're starting these. So just a quiz. What is the highest dose of buprenorphine transdermal patch in the United States? And the answer is 20. Next, we will move on to the moderate or high dose formulations of buprenorphine. These are your transmucosal, either coming in tablet or film versions. And you have buprenorphine with naloxone, commonly known as Suboxone, or you can have buprenorphine alone, also known as Subutex. So the FDA indications for these moderate or high dose formulations are for the use of opioid use disorder. Off-label, they can be used for chronic pain. And I would not use these in people who are opioid naive. So the dosing can be BID, TID, or QID when you're using it for the indication of pain. And when you're using it for opioid use disorder, it would be daily. So it depends on your indication for how often you're using it, but no, you can use it as frequently as QID. It reaches peak effect in 1.5 to 2 hours, and it usually lasts from 4 to 8 hours in duration. And in terms of dosages, so if it's buprenorphine alone, 2 milligrams, 4 milligrams, 8 milligrams, or 12 milligrams. And if it is combined with naloxone, that's what you have the second dosing, and those are the naloxone dosing. It's really important to know that you really have to instruct the patients that this is a sublingual medication. If you were to take it orally, the bioavailability is very poor. So they really need to take it sublingually. And the other concern that sometimes will come up, especially for patients who are using this not for opioid use disorder, but for pain, they'll ask about what the naloxone part. So the naloxone part would only be ever an issue if a person was supposed to trying to misuse the buprenorphine naloxone combo by injecting it. So it's trying to avoid people from injecting these medications. If they use it properly sublingually, the naloxone will have no impact. And from an access perspective, it can be hard to always get buprenorphine alone. Sometimes Suboxone, the combination, is more readily available. And so in that case, even if a patient does not have opioid use disorder, if you wanted to use Suboxone, it's okay. The naloxone is not going to cause any harm for a patient who's using it properly and for either the indication of opioid use disorder or chronic pain. So what is the dosing frequency of sublingual buprenorphine when the indication is for treating pain? The answer is E. So again, you can use it as often as QID, just depends on their pain. So now I'm going to go into some cases to really kind of work through how you would think about buprenorphine in these populations and kind of some of the nuances of prescribing. So case number 1, Ms. R is an 85-year-old female with hypertension and mild Alzheimer's dementia with chronic back pain secondary to spinal stenosis. She recalls after a hip replacement surgery, she was taking oxycodone 5 milligrams and it made her very dizzy and constipated. Because of that experience, since then, she has not used any opioids. Tylenol is no longer effective in managing her pain, and she asks, is there anything stronger, perhaps Tylenol with codeine? So what patient factors could lead to the consideration of buprenorphine use in this patient? So the fact she's chronic pain, she's opioid naive, she's maybe a frail older adult, and she didn't tolerate opioids in the past. And, for simplicity of this exercise, right, we're jumping to the idea of using buprenorphine in her. I brought up this example because it's not unusual in a lot of our older adults who have many comorbidities. Maybe they have atrial fibrillation on anticoagulation, or they have peptic ulcer disease, or they have heart failure, or they have CKD, all reasons why you can't use traditional pain management like NSAIDs, right? So that's a very common reason we can't use NSAIDs in this population. And we then have to think about what else can we use for pain if the Tylenol isn't working. So in terms of which formulations to consider using and at what doses, right? So we have an opioid naive, maybe frail older adult, and we want to use a buprenorphine. So we'd want to consider doing the low dose formulations, right? So you could either start with a 5 microgram per hour transdermal patch, or you can use the Belbuca buccal film, 75 micrograms daily. Again, starting low, going slow, but these are both opioid naive doses to start. Logistical considerations of prescribing these medications. So just being aware that depending on a patient's insurance, there may be prior authorization needed. And so one tool that has been useful is Cover My Meds, where you can create and register yourself as a prescriber to help with the approval process. Other things to be aware of is it may not be available at all pharmacies. And there's, already opioid deserts, let alone for some of these more specialized medications. And so as you're planning these medications for a patient, thinking about, is it available in the pharmacies I use or the patient uses? And thinking about maybe there's going to be a delay where you prescribe, the pharmacy then has to order it and wait for it to come in before the patient can even get it. So how you think about your timing of everything, your follow-ups, all of that. And then also just the cost itself, because even if it is covered by insurance, these can be very expensive. A monthly supply could be up to $150. So really counseling the patients about, if you go to the pharmacy and they're telling you have a really high copay, don't feel obligated to get it. Please give me a call and we can talk through it. Because yes, it may have all these benefits for you. And also we have to be realistic about your financial limitations or what's going on with the system we work in. So I also counsel people on that because I would feel really bad if someone, thought they had to get this medication and spent a lot of money and it's not sustainable or feasible for them in the long run. So in terms of patient instructions for the Butrans patch, like you prescribe the Butrans patch, how do you instruct the patient to use this? So it's really important you talk about rotating your application site each time you change the patch every 7 days. And you want to allow 3 weeks to pass before using the same site again to avoid increased drug absorption. So the insert, again, comes with this, but I tell patients, first time you can put it on your shoulder, or your outer arm or shoulder. Then you can do the next week on your chest. The following week, it can be on your back. And then the week after that, it can be on your side wall of your chest. And so this potentially gives you 8 possible application sites if you do a left and right for all of these sites. It's really important you clarify for a patient, just like the fentanyl patch, Butrans works across your whole body. So you do not put it where it hurts like a lidocaine patch, right? It's a systemic patch. So put it just in these general locations. Don't put it necessarily where you have the pain. It's okay to wear in the shower. You want to avoid prolonged heat exposure like saunas and hot tubs, as this can increase the absorption. And it's for some patients, there is this risk because it's an adhesive, it's a patch, it can cause skin irritation. If it's not bothersome to the patient, leave it alone. But if it's irritating and they can't tolerate it, it just may be that they're not able to tolerate the transdermal patch for that reason. And if the patient says like, oh, the edges, the patch are kind of rolling up, it's okay. You can use tape to tape down the edges to make sure it stays on if they're concerned. So what if we ended up with doing Belbuca instead of Butrans? Maybe she's worried about skin irritation and she wants to try something that's in her mouth. So this is a buccal version. It's important to tell them to moisten their cheeks before to help it stick and absorb. So I usually will tell patients, drink a cup of water before you do it, or rinse your mouth with water so it's nice and moist before you start. You want to place the yellow side of the film against the inside of the cheek, and colors can potentially help because, if they put the wrong side down, it's not going to absorb. And it is small, so you have to kind of be mindful of that. I've had some patients who are older who, due to arthritis and limitations with dexterity, they cannot be able to process or have the coordination to put these small films inside their cheek, or it gets all crinkled and kind of clumps up and then it doesn't work. So you have to kind of be aware of that logistic for a patient. You want to tell them to avoid eating or drinking until the film has completely dissolved, usually within 30 minutes. So, if they're going to eat before they put it in, not after, unless you wait 30 minutes. After it's dissolved, rinse your mouth with water and swallow, or you can spit it out. And you can wait an hour later, you can brush your teeth. So our next case, a case of Mr. L. This is a 40-year-old male with SCC of the tongue with history of opioid use disorder, CKD stage 4, anemia, hypertension, CAD, who's been on OxyContin 10 milligrams twice a day with oxycodone 5 milligrams PRN. He's not needing the PRNs as his pain has been well controlled though. So no PRN usage for cancer-related pain, but notes he has mucositis from radiation and has a high pill burden from his other medical conditions, and wondering if there were any patch options for pain medication. So, what patient factors would lead to consideration of buprenorphine use for this patient? So, cancer-related pain or chronic pain. He has a history of opioid use disorder, renal dysfunction, and for him, because of his mucositis, it's hard for him to take PO or SL medications. So, knowing that, what formulation of buprenorphine would you consider using in him and at what dose? So, this is where Butrans can be very handy, right? It's transdermal patch option, so not anything in the mouth that could irritate or bother his mucositis. He isn't opioid naive though. And so because his oral morphine equivalence is between 30 to 80, you would use a 10 microgram per hour patch as your initial dose. And how would you counsel him to use the patch if he's already on an opioid? So one of the simplest ways is say in the morning that you were normally going to take your OxyContin long acting, 10 milligrams, don't take it. And instead put on the patch. And, again, counsel, it can take some time to take effect, so not rip it off just because there's nothing felt right away. It does take some time. And while we're waiting for the patch to take effect, it's okay for him to use his oxycodone 5 milligrams PRNs to get him through this period of loading up the patch into his system. And it's also important to know that even once the patch is fully working, if he feels he needs to use a PRN, oxycodone, he can. Just like if he was on OxyContin and felt he needed a PRN, he can. And the reason this patch is possible in working without causing problems is a very low dose. Remember from before about the receptors being gradually occupied. And the other thing to know is once you have buprenorphine on board, it's totally fine to add a full agonist opioid on top, and it will not cause a withdrawal. So again, remember that picture from earlier, just with a patch, we're slowly putting on the buprenorphine into the system, and then eventually it will take over as the oxycodone leaves in this case. So you can potentiate withdrawal by adding a large amount of buprenorphine to someone already on a full agonist, but the reverse is not true. So you will not cause any problems for a patient who is on buprenorphine and you add an agonist. And that's why you can use your PRNs of whatever you want, oxycodone, morphine, hydromorphone, in someone who's already on buprenorphine. So what if the 10 microgram per hour patch wasn't enough? You're troubleshooting it, and how do you think about what to do next? So after 72 hours, when you've reached steady state, you can consider going up on the dose. However, that can sometimes be confusing, and it may be hard for you to, be talking to a patient so quickly after the visit. And so logistically, I found that it's a lot easier to make these changes at the 7-day mark when they're going to change the patch anyway. So that's the first thing to think about is like maybe make your changes when they're going to change the patch at the 7-day mark. And depending on the degree of the pain is how you can think about your titration. You really want to titrate buprenorphine based on their pain. You're not doing any math or conversions. So if the pain is mild, moderate, like it could be better, but it's not terrible, you could just decide to go up by 50% or to 15 micrograms per hour. However, if the pain was really severe, not well controlled, you could say, okay, well, then let's do a 100% increase and double the dose. So in this patient's case, who's on a 10 microgram per hour patch, you could say at your next patch change, let's put on 2 of the 10 microgram per hour patches. So it's equivalent to them wearing a 20 microgram per hour patch. And I just tell them, put the 2 patches next to each other at a new site completely from, the first patch they had used, but just have them side by side. And then see how they do. And this kind of helps the patient because a box of patches is usually 4. They've tried one of them, they have 3 left. It's a way to kind of use up what they've already had and try out a dose before you have to necessarily re-prescribe a whole new prescription. So that's why a lot of times I will try going from a 10 microgram per hour patch to a 20 microgram per hour. But it's totally acceptable. And depending on severity of pain, if it's only a little bit and you only want to do a slight increase, you could just write a new prescription for a 15 microgram per hour patch. Okay. So for instance, what do you do when a patient gets admitted to the hospital and they're using these patches? So it depends why they're being admitted to the hospital. If it's for uncontrolled pain, remove the patch and proceed with pain management like you normally would in a pain crisis, right? Use your short-acting IV opioids to do whatever you need to do. There again, no risk for any precipitated withdrawal. Just treat as you normally would with any crisis where you kind of get the long-actings out of the picture and use your short-actings to figure out how to manage the pain. If they're admitted for a non-pain related admission, say they're there for a urinary tract infection or pneumonia, their pain's stable, you could say, let's just leave the patch on, use your full agonist PRNs as usual, but you would have to think about, okay, if the patient is admitted during their next patch change or they're there for a long time, you have to think about either having your patch on formulary or they have to bring it from home as a non-formulary. So thinking about that so they can keep on their patch without having any major changes. So our next case, the case of Ms. W. So this is a 72-year-old female with multiple myeloma with worsening cancer-related pain who has been taking OxyContin 60 milligrams BID and oxycodone IR 10 milligrams Q4 hours PRN for breakthrough pain. She notes in 24 hours taking 6 breakthrough doses, no history of opioid use disorder, or no history of opioid use disorder. However, she notes lately she sometimes will take the PRNs for reasons other than pain and is bothered by feeling decreased control over her oxycodone use. She also finds that even with higher PRN use, her pain isn't as well controlled these days. She wonders if there were any other medications she could try that would maybe make her feel less dependent. So what patient factors would lead to consideration of buprenorphine in this case? Well, we have worsening chronic cancer-related pain, and there's possibly this risk of opioid misuse, and that's the idea that she will take the pain medications for reasons other than pain, and just that sensation or feeling of less control over her use. So kind of just acknowledging that the opioids aren't maybe working as well as they used to for her as well. So which formulations of buprenorphine could you consider using? And again, this is someone who's on much higher doses, right? OxyContin 60 milligrams twice a day and oxycodone IR 10 milligrams Q4 hours. So let's use a little bit of math to kind of give us some guidance. So first we want to know what her oral morphine equivalents are because that'll help us decide are low dose formulations realistic for her, or maybe we're going to be needing the higher dose formulations of buprenorphine. So when we convert our OxyContin into our oral morphine equivalents, you always just want to make, add up your 24-hour usage of everything. So 2 doses of OxyContin 60 milligrams is 120 milligrams. And then if she's using 6 of her PRNs, that's 60 milligrams. So she's using 180 milligrams of oxycodone in 24 hours. And you can do your calculations to convert this, which is equal to 270 oral morphine equivalents. So 270 oral morphine equivalents is much higher, right, than our low-dose buprenorphine formulation should be able to handle. And so they really would not be the solution for her. You could consider starting with that and then knowing you're going to go higher and higher to the sublingual, moderate, high dose buprenorphine formulations. But you would not expect that the low dose formulations would be enough for her amount of pain. So you also don't want to just jump straight into a sublingual 2 milligrams of buprenorphine because of the risk for possible precipitated withdrawal. So what do you do? So this is one of the ways to gradually put someone onto buprenorphine. And this is adapted from Becker et al. And there are many different case studies or reviews that walk you through how to get someone onto buprenorphine who's already on a high dose of a full opioid agonist. So there's no one correct way. There's no randomized controlled trials either that say this is the one way to do it. But I bring this up as this relatively straightforward path, and it does have a nice table to kind of walk you through the steps. So this is just a theoretical option to consider. But the important factors to realize is someone is already on a high amount of a full opioid agonist, and therefore you have to slowly add on amounts of buprenorphine at low doses and gradually go up until the receptors are nicely switched over, so you avoid that abrupt withdrawal. So on your first day, you may say take 0.5 milligrams of the sublingual buprenorphine film. Remember, the smallest tablet or film size for the sublingual is 2 milligrams. So you have to be able to either do this for the patient where you cut it into quarters to get a 0.5, or they have to be able to follow instructions. But you would say give a quarter of the film twice a day. You would say keep your long-acting OxyContin, take it like normal, and keep taking your short-acting as needed. On the second day, you would tell them to take 1 milligram of buprenorphine BID. So this would be half of a 2 milligram film twice a day. Again, keep your long-acting the same, keep your short-acting the same. On the third day, you would go up to 1 milligram TID. So still a half a film, but more often now, keeping your long-acting the same. On the fourth day, you could do a whole sublingual buprenorphine film 3 times a day, but you decrease your OxyContin long-acting in half. So now you're doing 30 milligrams BID, and you still have your PRNs. On the fifth day, you go to 4 milligrams TID, and you stop the OxyContin completely, and you continue with your PRNs. Now, you may not need to go to higher doses. 4 milligrams TID may be sufficient, but you're just going to have to titrate up depending on how their pain's doing. There's no one right answer, and it's not a conversion either. It's really based on how they respond. So if 4 milligrams TID of buprenorphine works for them, great. And again, you have your oxycodones as needed, and that could be on for the remainder of the time they're on buprenorphine. So then, if they're good, you just leave it alone. If their pain's not well controlled, you could jump up to 8, or you could kind of do somewhere in the middle. You'll just have to see how they're responding. But the point is you go low with your buprenorphine and you eventually switch over to the higher doses. Some clinics or providers will set up pill boxes where they, pre-cut all these pieces for the patient. So it's very clear on this day, I take a quarter of a film, this day I take a half a film, because it can be hard to follow those instructions. There are some pharmacies that will do this blister packing as well. So just be aware that's a potential option, and also be aware of the health literacy of your patients, how much can they handle, because it can be tricky to go through all these instructions. And there are definitely some patients where this is very overwhelming and they need either a lot of support or it's not possible to switch over as easily because of some of the logistics of the health literacy. But this is, again, one option for doing it. So we're come to the end of the presentation. Here are the answers to the true or false questions. Hopefully throughout the presentation, I answered them, but here they are if not. And in conclusion, just again, buprenorphine can be used for the treatment of pain or opioid use disorder or both. It has a lower risk of respiratory depression compared to other opioids because of how it is a partial agonist. But partial agonist does not mean partial analgesia. It just means other pathways triggered by the receptors aren't as activated. There are many different formulations of buprenorphine that can be used. You have your low dose formulations that are great for people who are opioid naive or not needing a lot of opioids. And then you have your moderate high dose formulations. You do not need any special X waiver to prescribe buprenorphine. Any physician with a DEA waiver, you do not need a DEA X waiver to prescribe buprenorphine. Any physician who has an active DEA that can prescribe other opioids can prescribe buprenorphine. And if you're a non-physician prescriber, just check with your individual state's laws about buprenorphine itself. Just know that it's okay to use your full opioid agonist as breakthrough when someone is on buprenorphine. And really just, again, consider those patients for buprenorphine who you worry may not tolerate a traditional full mu opioid agonist, right? The people who have ESRD, the people who are at risk for respiratory depression because of either comorbidities or other medications they're using, or those who, have had problems with hyperalgesia. So it can be, again, another tool in your toolbox whenever you're considering using an opioid. And that's all I have.